Starting with the first image, we see that normally, so the question is whether we really need every time contrast-enhanced ultrasound. If we look at the anatomic area here, the aorta, we're starting with a grayscale image. In this image, everything is clear. We see no plaques. We see no movement membrane, so no aortic dissection, no aneurysm. And also on the longitudinal view, we see this nice shape of the aorta. So in this case, there is no need to use contrast-enhanced ultrasound. Also, we use the next step. The next step will be color Doppler information. We see a nice filling of the aorta. We see also the IVC here. We see a normal curve from the aorta. And also in the longitudinal view here of the aorta, we see no turbulence. So also major information already exists in this image. There is no need to use contrast. But if we think about pathologies, for example, the aneurysm, there we have to use contrast. If we think about how much contrast is necessary to get a good contrast, we use only 1 cc of contrast and followed by 10 cc of saline solution. The amount of contrast is a little bit different on the different system. So sometimes you need a little bit more contrast, but on average you use only 1 cc of contrast. Starting with aneurysm. Of course, an aneurysm is called an aneurysm if the diameter is more than 3 centimeters. We also know that in the Western Union we have got a higher risk to develop an aneurysm in comparison to the other areas in the world. And unfortunately, also most of the men have got the risk to develop an aneurysm. And of course, depending on the diameter, the risk that the aneurysm could rupture will be increased depending on the diameter. So starting with the first patient, that's an 85-year-old patient, no trauma in history. He finds pulsation, abdominal tumor, and pain. So we see a huge aneurysm. It has got a diameter about 10 centimeters. Also on the longitudinal view, we see it partial thrombotic changed in the aneurysm, but we could not exclude any rupture in this case. By using the next step, using color Doppler information, we see that there is still a flow inside, with some turbulences inside. That's the iliac arteries, the right and the left iliac arteries. And also on the longitudinal view, we see here part of the iliac artery. But we could not exclude a rupture in this case. So therefore, it's helpful to use contrast. So by using contrast, we see contrast stays in the aneurysm. It doesn't leave the aneurysm. So only a huge abdominal aortic aneurysm with a diameter about 10 centimeters with thrombotic changes, but no sign of a rupture. This patient will, in the most time, treated by aortic stent grafts. Unfortunately, a stent graft implantation was not possible. A couple of days later, this patient died. If we think about arterial dissection, often we find in the grayscale the movement of the membrane. Sometimes the question is whether both lumen has still a flow inside, yes or not. And what about the perfusion of the kidney? You have to look really carefully at the kidney because most of the time either the right or the left side of the aneurysm of the dissection will enter from the fourth lumen. So starting with a grayscale image, that's a 70-year-old patient with pain for 2 days, come to this ultrasound examination. The diagnosis is clear. It's an aortic dissection. We see here in the longitudinal view the movement and the membrane. But could we answer the question, where's the true lumen? Where's the fourth lumen? Of course, we see it also in the axial view. Here, probably, if we have experience, you see the flap moves more in this direction in comparison to the other. Probably this will be true lumen, this will be the fourth lumen. So we look at the color Doppler, we see there's still a flow in both lumen, but we see also that the color settings is a little bit different, so there must be different flows in both lumen. So where are the additional information by using contrast in this patient? First of all, we look at the timer, we inject contrast, that's the dual mode. First of all, the contrast arrived in the true lumen, then in the false lumen. And if you look very carefully, here we see the right renal artery. Also here, that's the true lumen, false lumen, and here is the right renal artery. But where are the left renal artery? Could we see it? Really hard. I couldn't find it. Next step, I look at the perfusion of the kidney and compare it to part of the liver. The perfusion of the kidney is nice, no infarction. And if you compare from the complete side of this kidney, all over nice perfusion. So the question is why we only find the right renal artery, because this patient has got only one kidney. Here we see the dissection of the aorta, that's the fourth lumen, and the right renal artery entered from the fourth lumen. Therefore, it's very important to look very, very carefully on the right kidney, because he has got only right kidney, who is entered from the fourth lumen. Covered rupture is a very rare case. Therefore, it's very important to see maybe a hematoma or an active bleeding in this hematoma. But are we able to see these bleedings or not? Starting with this case, that's a 57-year-old female with abdominal pain in the last 4 days. We're starting with the grayscale. In the longitudinal view, we see a calcification plaque. We see in the axial view a little bit unlucky shape of the aorta here. But could we exclude a rupture here? If we compare with contrast, we see that below this plaque is still contrast in the longitudinal view. So there must be a rupture, otherwise the contrast could not be below this plaque. Also in the axial view, we see the shape and the hematoma here without contrast uptake. And if we compare this now to the CT examination, we see here the rupture, covered rupture of the aorta, also here in the sagittal view, and this was treated by an aortic stent graft. A very uncommon case is a rupture from the aorta in the IVC as a sign of a fistula. So this patient, 60-year-old patient, suspicion of a symptomatic abdominal aneurysm. We started with grayscale. We see this aliasing here next to the aorta. So there's suspicion of an IV fistula. But could we see this fistula? It must be somewhere here. Yeah. Also in the longitudinal view, we can see that must be here in this area. But how many fistula exist in this case? Starting with contrast, aorta, there's a channel between the aorta and the IVC, and the second channel here. Again, one channel, and here is the second channel. So 2 fistulas from the IVC from the aorta in the IVC. And of course, we have done dynamic MRI examination and also CT examination. If we look at the dynamic MRI examination, we see this filling of the aorta, we see this aneurysm, we see the aneurysm of the iliac arteries, we see the filling of the iliac arteries, but we could not see any filling in the iliac veins. But we have still contrast in the IVC. So the contrast must take this way from the aorta directly in the IVC. Otherwise, it makes no sense that these contrasts arrive so early in the IVC. If we compare this to the CT examination, we see it also similar. We see here the aneurysm, the iliac arteries, no iliac veins, and we could see here the IVC filled with contrast due to the fact that that's a fistula. But in CT, or also in MRI, there was a suspicion only of one fistula, but there was 2 fistulas at the end. Therapy of this patient was also aortic stent graft. An inflammatory aortic aneurysm is a very rare case. The first was described by Walker in the year 1972. So it's about 2 to 15% of these aneurysms could be inflammatory aneurysm. And often we see an enlargement of the aortic wall, of course, with more small vessels inside. This patient was already treated the aneurysm by an aortic stent graft. We see here the aortic stent graft. We see that's normal aortic wall. And then we see this enlargement of the anterior and lateral and ventral part of the aortic wall. By color Doppler, we see that the stent graft is fine. We could not see any endoleak, but this session will be coming later. But we could not see any flow here, no major vessels. Also, if we use the power Doppler settings, we can see here the stent graft is nice perfused, but we could not see any flow here in this enlarged aortic wall. So, are this technique sensitive enough to detect a perfusion of the aortic wall? We inject contrast, we see the perfusion of the stent graft, that's fine. Take a little bit while, and then we see this filling of the inflammatory aortic aneurysm here, especially on the ventral part and on the lateral part, due to the fact that it's an inflammatory aortic aneurysm. These aneurysms will be often treated, and therefore as the next step for contrast ultrasound, you can monitor this treatment. If you do this examination before treatment, and use this time-intensive curve as a baseline examination and then compare it over time, you can say whether your treatment are successful or not. This is the same patient. This was CTA, MIP, so we couldn't see it, but we see the part of the aneurysm before. And we see here the aneurysm, and this is the wall uptake, and this was the stent graft. If I compare it, you can see and make measurements inside here, and then you get this nice curve, which you have already seen in the kidney diagnostics, and then you compare side by side the changes. So in conclusion, for the first, we can say the use of contrast-enhanced ultrasound is very helpful to detect all the major pathologies in the abdominal aorta. Thoracic aorta is also possible, but that's a special part and even more difficult. We have additional information like perfusion of the real and false lumen in dissection, and also perfusion of the kidneys, which is really very important. If there's less perfusion, you need an intervention. And it's additional examination to CT and MRI. Of course, if we find in the grayscale image an aortic dissection, we need the CTA because we want to know how far does the dissection go. The thoracic dissection is next to the heart, does it go in the carotid arteries, so this patient also received a CT. But in the follow-up, on the intensive care unit, you can look at this patient on the bedside examination and compare whether both lumina have still contrast uptake or not, or what about the perfusion of the kidney, and there's no need to bring this patient again to the CT or the MRI department. You can do this on the intensive care unit next to the patient in the bedside examination. And of course, this technique is also very helpful for the preoperative planning. If we think about the covered rupture or the covered rupture where the question was, how far are the renal arteries away from the covered rupture? We could answer the question very, very clearly and say, this patient needs a special stent graft. A normal stent graft will not work here. And this also was confirmed by the CT examination. And therefore, for the preoperative planning, this tool is also very helpful to find the correct or best treatment for your patient. Thank you much for your attention.